I'll be speaking on vascular endothelial growth factor in retinal vein disorders and its importance in clinical practice. So as we all know, retinal vein occlusion is the second most common cause of retinal vascular disease after diabetic retinopathy, with a prevalence of 1 to 2% in persons older than 40 years of age. And macular edema is the most common cause for decreased vision in such patients. And usually they are associated with hypertension, diabetes, and in younger individuals, you need to rule out other causes. So macular edema, the old concept was that there is a clot sitting in the lumen of the vessel, and the blood is not able to leave from that area, and it leaks out of the blood vessels, and the fluid gets collected in the retina. This was the old concept that we were taught how macular edema happens. But if that is the only cause, then how does the anti-VEGF work so rapidly? Anti-VEGF is not going to release the clot. So the current thinking is that the increased venous pressure, because we block, impedes arterial flow. And this causes ischemia and release of angiogenic factors. So thus the anti-VEGF works like an antihistamine and stops the leakage. And once the effect wears off, the leakage starts again. So inflammation also plays a part in RVO. So by a study by Richard Green, he showed that there is a lymphocytic infiltration within the wall of the vein or into the thrombus. And the elevated expression of angiogenic cytokines such as VEGF and many inflammatory cytokines including IL, 23, 8, 6, 15, 12, 17 have been reported in the ocular fluids of patients with BRVO and CRVO. So the aqueous humor levels of vasoactive molecules correlate with vitreous levels and macular edema in CRVO. And similar thing has been found that the aqueous levels of cytokines are correlated to the vitreous levels and the severity of macular edema in BRVO. So what does it tell us? That aqueous sampling is good enough. So aqueous VEGF levels and the vitreous VEGF level, there is a good correlation. So you don't have to really go for a vitreous tap, which can be traumatic and fraught with complications. So aqueous sampling is good enough. So if you look at this, there's a patient with CRVO on the left side and the BRVO on the right side. So at presentation, it is difficult to tell whether this patient is going to receive 4 injections, 5 injections, what is the natural history of the disease going to be. On the left side, the CRVO patient just with 2 anti-VEGFs did well. But this BRVO patient had 6 anti-VEGFs, 1 IVTA, 2 sittings of laser, and it was a very protracted course of treatment. And we don't know what is the exact reason for response, non-response, recurrences. And very few studies have looked at the VEGF concentration over time and compared it against the clinical onset, persistence, or regression of NVE and changes in vasopermeability. So we were thinking that if the patient presents at time and if you can get the VEGF level, so whether that could give you some idea how the patient is going to behave. And in cases of CRVO, so we try to see that which is ischemic, which is non-ischemic. So we'll look at RAPD, visual acuity, fundus photographs. If we could add one more effect into that, that is the VEGF concentration. So whether it is going to help us clinically. So we did a small study. The purpose was to look at the role of aqueous VEGF in macular edema secondary to RVO and to tailor treatment according to the aqueous VEGF levels. So it was a prospective pilot study, 25 of 25 patients, that is 15 cases with RVO with macular edema and 10 controls. And we used the flow cytometer, that is BD cytometric bead assay, to calculate the VEGF levels. So inclusion criteria was patients with RVO and no other retinal pathology and macular edema seen on OCT. And exclusion criteria was if the patient had received injection or laser in the recent past, evidence of NVG and ocular inflammation. So the patients underwent visual acuity, IOP, fundus photo, OCT, and FFA if indicated, and then undiluted aqueous sample was collected, and it was rapidly frozen to -80 and then sent to lab for immunoassay using the BD CBA human VEGF flex set. and then the patient received intravitreal Avastin. And at 1 month, we looked at the visual acuity and CFT of these patients. So here you can see that aqueous VEGF level in the CRVO group was 295.13 picograms. In the BRVO, it was 27.9, and in the controls, it was 20. So the patients with CRVO had more level of aqueous VEGF as compared to BRVO. And the CFT, that is the central foveal thickness, also was more in the CRVO patients as compared to BRVO. And this is the CFT pre and 1 month post injection. So you can see there is a improvement in almost all the patients after receiving the intravitreal Avastin. And this is a box plot comparing VEGF levels between CRVO and BRVO. So CRVO, definitely the VEGF levels will be more as compared to BRVO. And there was a weak correlation between CFT and aqueous VEGF levels, and we did not find any correlation between visual acuity and VEGF levels. And response to treatment, so basically all patients responded to the treatment, and we sort of try to divide them into optimal response and suboptimal response. Optimal response was when after injection, if the CFT decreased by more than 50 microns, it was a optimal. Suboptimal, CFT less than 50 microns. So around 7 patients had low VEGF, but they also showed good response, optimal response in 5. And high VEGF was seen in 7, and optimal response was seen in 6. So basically, this is one patient where we changed the treatment based on the VEGF levels. So this is at presentation, the visual acuity was counting finger at 2 meters. They received Avastin, and at 1 month, there was no improvement. And then we looked back at the VEGF levels. So this patient had low VEGF levels. So here we gave IVTA, and the patient responded very well. But we saw it the other way also. So sometimes patients with low VEGF level also showed optimal response to anti-VEGF. So this has been proved that Avastin or anti-VEGFs probably interfere with other inflammatory cytokines other than VEGF. So that explains the efficacy. And Avastin reduces the ocular VEGF levels along with inflammatory cytokines. So to conclude, our results provide evidence of a disturbed balance of VEGF in eyes with RVO compared with control eyes without vascular disease, and aqueous VEGF levels were significantly increased in the aqueous humor of our patients with CRVO and as a trend in patients with BRVO. And this estimation may help in planning targeted treatment. So basically, one use could be that sometimes we inject patients with CRVO with one injection and the OCT becomes totally flat. But at the back of your mind, you always know that the edema could come back. So in such cases, if you can get a VEGF level done, and if it shows raised VEGF levels, then you may still inject the patient. So in that way, it could help us. Another could be that patients with low VEGF, you could always think of giving anti-VEGF along with steroid. So we have a small number of cases, but it looks promising. I think it could be the way that we could be managing patients with vein occlusions. Thanks.